I'd like to start with a case study. This is the case of Mr. A. You may be familiar with this case study because it was published in the American Journal of Psychiatry in 2008. And Mr. A is a 56-year-old gay-identified Caucasian male who died 2 months after being discharged from a psychiatric unit in the US. He had been in and out of hospital many times, over 10 years or more. And he had various diagnoses of schizoaffective disorder, major depression with or without psychotic features, post-traumatic stress disorder, polysubstance or stimulant dependence. And he had a college degree, but he was on a full disability pension because of his psychiatric disability. This is a true case study. In investigating his death, the police found at the scene, where his body was found at home, a styrofoam cup on the bedside table and some empty medication vials. There was no evidence of foul play or involvement of another person, and there was no evidence of alcohol or illicit drug use. When the police spoke to Mr. A's neighbour, they said that he was frequently too stoned to remember to lock his door. And when the police spoke to his psychiatrist, the psychiatrist added anxiety and insomnia to his long list of problems, along with medication abuse and suicidal ideation. Again, in examining the death, a medical examiner's report described Mr. A as obese. He had no acute fatal traumatic injuries evident. There were no pill fragments or foreign bodies in his gastrointestinal tract. The toxicology report detected some medications, but they were all within therapeutic levels. There was no evidence of suicide or accidental drug overdose. Mr. A died from complications of pulmonary emphysema due to tobacco use. The autopsy showed many signs of cardiopulmonary disease, but none of these were recorded in his hospital records. There was some sporadic mention of hypercholesterolemia, use of beta blockers and a heart murmur. And Mr. A's chronic use of tobacco was noted in his chart. And so in thinking back to his last consultation while he was still in hospital, the staff looked back on those notes of his last consultation and they saw that Mr. A had mentioned that he was a 2 packs a day smoker and that 10% of his income was going into buying his smokes, and that he had made many, many quit attempts in his lifetime and at least 2 in the last 12 months. And each one of those quit attempts was unassisted. He had not received any advice to quit in the last 12 months, despite being in and out of hospital. And he had not received any evidence-based treatments or therapies for his tobacco smoking. They did give him some self-help material to help him during his stay in a smoke-free hospital, but obviously he relapsed back to smoking following discharge. So what does this case of Mr. A tell us? Well, it tells us lots of things. And one of the things it tells us is that people who smoke now have many complex co-occurring problems. And so they often have repeated visits with healthcare services and healthcare providers. And often these health services and healthcare providers are aware of the tobacco smoking, and in this case, in Mr. A's case, they were aware. It was noted on his charts that he had a nicotine addiction, but his other drug use and mental health problems were prioritised. It was the tobacco that killed him. He had made numerous quit attempts. He really wanted to quit, but he had not been given any evidence-based nicotine dependence treatments. And so he kept relapsing to smoking. Helping him stay quit was very, very hard. And this is typical, unfortunately, for many of our smokers now. Estimates are that the seriously mentally ill die 25 years earlier than the general population, with tobacco-related conditions of heart disease, cancer, cerebrovascular disease and chronic respiratory diseases as the leading causes. So I don't think I need to tell this audience who I mean when I refer to priority groups or high priority groups for tobacco smoking. There's been a lot of sessions about priority groups, and I certainly won't go through the academic definitions of high priority groups. You can find those in lots of literature. But generally speaking, they are people who are socially disadvantaged. They are from low socioeconomic status. They are vulnerable, they are marginalised people in our society, and they have very high smoking prevalence rates, and they should be our priority. A lot of the Australians in the audience should be familiar with this graph. And it shows our smoking rates since 1991. And as you can see by the blue line, smoking has decreased significantly from around 30% down to 15% or even lower, depending on which reports you read. As you can see, never smokers has risen over time, but there's been a bit of a plateauing of ex-smokers in Australia. But my focus today is on high priority groups and smoking, so I'd like to look more closely at that blue line of smokers. And I'd like to look at it by socioeconomic status. And a lot of you will probably be aware of this graph as well, and it shows the blue line, shows the smoking prevalence rates of people in our lower socioeconomic groups in Australia. And as you can see, it's much higher than the green line, which is the smoking rates of our higher socioeconomic groups. And you would also notice that there's been a decline across both lines or both groups in smoking rates over time, which is just terrific. However, the gap between the low and high socioeconomic status groups and smoking rates is growing. And it has continued to grow even between 2010 and 2013, where we see the sharpest declines in smoking rates across the two groups. Between 2010, there was a 4.7% drop in prevalence of smoking amongst our low socioeconomic groups, which is the best that we've ever achieved. But there was a 5.8 drop in prevalence rates in smoking amongst our higher socioeconomic groups, and this is causing that gap to widen. Now, like in most countries, Australia has a national policy target for smoking, and it's 10% by 2018, and there's been a number of people that have referred to that. We also have a target for Aboriginal and Torres Strait Islander people to halve rates among those populations. And we're well on track in achieving that goal, particularly if we look at high socioeconomic status areas. We'll probably get down to 5% by next year, which is remarkable. It's extraordinary progress. But amongst our lower socioeconomic quintile or groups, even by 2030, we will not have achieved a 10% smoking rate if the gradient of the slope continues to remain the same. This is only telling part of the story. Of course, there are other social groups or high priority groups in our society that have much, much higher smoking rates. People with mental illness, between 35 and 88% has been reported. People who are homeless, 69 to 93% of people in those samples have been smokers. Aboriginal Torres Strait Islander, 38 to 45%. Prisoners, 70 to 92%. These rates are very reminiscent of smoking rates in Australia in the 1960s. And there is evidence that smoking rates are just not changing over time for certain groups. And the wonderful Anne McNeil plotted this data using UK data. If you focus on the graphs on your left side, the top graph shows smoking prevalence by mental health status, and the top line in that graph is people with mental illness, and the bottom line is people reporting no mental illness, and you can see that smoking has been declining for people without a mental illness, but it has stayed the same for people with a mental illness. If you plot daily cigarette consumption, which is the next graph below, you get the same sort of pattern. And then interestingly, the bottom graph on the left-hand side is desire to quit, and there's no difference between people with a mental illness and people without a mental illness. They all want to quit. We've got a little bit of Australian data, not quite that detailed, but it comes from two nationally representative and fairly large samples of people with psychotic illness, one conducted in 1997 and one conducted in 2010, and smoking rates amongst people with severe mental illness have not changed in that time frame. So we need to do something about this. And what else do we know about smoking behaviours amongst high priority groups? And understanding smoking behaviours will hopefully help us develop better programs. Well, compared to the general population, these smokers are more heavily nicotine dependent. They smoke more cigarettes a day, they report lower self-efficacy or self-belief that they can quit, probably because they keep attempting to and never quite sustain a quit attempt. They're less likely to plan a quit attempt in the next 6 months, and they're less likely to receive healthcare provider advice to quit smoking. All of this leads to much lower quit ratios amongst our high priority groups, which means that even if they make the same number of quit attempts as smokers in the general population, those quit attempts are not converted into sustained cessation like they are more likely to be for smokers in general population or more advantaged groups. So why the quit rates? Why are they so low amongst our high priority groups? And as we've already mentioned, and many sessions at this conference have outlined, it's not through lack of interest in quitting. We conducted a survey of over 600 highly disadvantaged smokers. Of this sample, 16% were Aboriginal or Torres Strait Islander, 93% lived on government benefits as their main source of income, 62% were either homeless or in supported accommodation, 56% of the sample scored high for anxiety and 59% reported clinical levels of depression. 63% consumed alcohol at harmful levels. They wanted to quit their smoking. This is a sample drawn from New South Wales. They had been attempting to quit their entire life. A lot of them had made 2 or more quit attempts in the last 12 months. And there was high motivation to quit smoking. They'd like some serious advice from someone who actually cares. We also asked these smokers from our high priority groups, what aid did they use at their last quit attempt? And for half of them, it was nothing. They had just tried to quit on their own, unassisted cessation, so it's clearly not doing them any good. There were small proportions who had tried nicotine replacement therapy or getting help from their GP, varenicline and other stop smoking medicine, small proportions using telephone support. Obviously, there's not enough use of evidence-based treatments and interventions here. There was some use of non-evidence-based treatments like acupuncture and hypnosis and shark cartilage and other things. So we thought, well, why don't we take the evidence-based treatments to our smokers in high priority groups? And so we ran a trial of smoking cessation treatment in community social services, which is where we recruited our original sample of 639. And we looked at cessation as the primary outcome. We used the gold standard measure of cessation as continuous abstinence at 6 months follow-up. And we also measured some other things like average number of cigarettes smoked per day and quit attempts. And I won't labour on. It was a randomised control trial. There's a protocol paper, you can read it. And people in the intervention group received behavioural counselling, gold standard evidence-based treatment, behavioural counselling, options for different types of nicotine replacement therapy, combination use of therapy. It was all provided free. Quitline referral if they wanted more help. There was a social support component to the intervention, a buddy system. It was all based on extensive formative research which has been published. It was based on Robert West, the wonderful Robert West prime theory of motivation, and we included strategies to boost recruitment and retention because they are still hard to reach populations that we're talking about. And basically, by the end of it, at the end of 6 months, we found no difference in cessation, in sustained cessation at 6 months between intervention and control groups. There was differences in the number of cigarettes smoked per day. So people in the intervention group smoked fewer cigarettes and had more quit attempts, so 3.6 quit attempts versus 1.6, which is great. But clearly we're having trouble helping people convert those quit attempts and reductions in smoking into sustained cessation, long-term cessation. So then we thought we'd look at, well, what are the barriers to quitting for these populations? And we reviewed the literature. We conducted a systematic review and identified 61 studies that included both qualitative and quantitative data reporting the self-perceived barriers to quitting for 6 key priority groups: homeless populations, low income, people with mental illness and substance abuse, Indigenous populations, at-risk youth and prisoners. And we found some barriers that they were reporting some barriers that were common to general population of smokers that we've heard before, things like stress management, enjoyment of smoking, their addiction, it's a habit, fear of weight gain or actual weight gain when they do quit. So there were some common barriers across priority groups as well as more advantaged, sort of what you'd find in the general literature. But there were important differences as well in that there were high rates of barriers that were reported that were about social and community networks and their living conditions and their environmental factors and cultural and socio-economic factors, high prevalence and acceptability of smoking in their communities, a lack of social support, smoking as a social activity. So even if you give them all these evidence-based treatments and they're really keen to quit, they then go home and they're confronted with a family or an entire community that smokes. And smoking is accepted and smoking is actually part of your social life. So these are important barriers. High priority groups are characterised by layers of complex co-occurring factors contributing to their social disadvantage. Smoking rates are high amongst high priority groups and they've changed a little over time. Smoking rates amongst more advantaged groups have declined, and this has led to the creation of tobacco inequalities. Why has this happened? A number of individual factors contribute to high smoking rates amongst high priority groups, and this leads to low quit rates. Use of evidence-based cessation methods is low, and there are social and environmental barriers to quitting that affect smokers in high priority groups. So how do we reduce tobacco-related inequalities? This is an important public health priority in Australia and in most countries, but we have been hampered in the development of our programs by a lack of evidence to demonstrate how to reduce our inequalities. And in addressing inequalities of any type, tobacco or anything else, requires a prioritisation of efforts targeted at the disadvantaged. And this can be tricky because even where interventions are successful at improving health across the population, they may increase health inequalities. And this can happen where an intervention is of greater benefit to more advantaged groups than disadvantaged groups. But we can reverse it by designing interventions that are of greater benefit to disadvantaged groups. And there's been very good people overseas who have reviewed the tobacco control literature, trying to identify which of our interventions are good at targeting disadvantaged groups and being of greater benefit to disadvantaged groups than advantaged groups. And generally, these very comprehensive reviews have found, as Frank Chalupka has covered in his session, that the strongest evidence for reducing inequalities is taxation and price increases, although there are other problems associated with that for people who are on low income. And there has been evidence that mass media can increase inequalities, but more recently there have been the development of messages and mass media campaigns that are targeted at low socioeconomic groups, and they have the potential to decrease inequalities in tobacco. In a lot of our other interventions, there's just very little evidence to be able to say anything at all. And as far as our individual cessation interventions are concerned, these reviewers found that the strongest evidence for reducing tobacco-related inequalities came from the combination of behavioural and pharmacotherapy interventions that target low socioeconomic groups. But as far as our other individual cessation interventions are concerned, there's very little evidence available, and what does exist suggests that they may be contributing to our inequalities. So we have a bit of a lack of evidence, lack of effectiveness evidence, and in particular we lack evidence that's local, that's Oceania. There were only 4 Australian studies included in those reviews outlined in those previous 2 tables, and only 1 New Zealand study. And this is changing. There are some trials around financial counselling and NRT for low socioeconomic status groups, and organisational change trials for people in drug and alcohol treatment services. And as we've seen at this conference, there's numerous pilot research happening that is really important, but we do need to convert that pilot research into large, well-powered trials. I'd like to just outline some priorities for addressing tobacco and building tobacco inequalities and building an evidence base in this area. And one of the first things I think that we need to do is our 10% target for reducing tobacco smoking in Australia needs to have equity goals associated alongside the Aboriginal and Torres Strait Islander goal that we have. For all our tobacco control activities, we need to monitor effectiveness across social groups, and we need to monitor whether there's any unintended harms as well. The evidence that does exist suggests that interventions that are targeted are the ones that are most likely to benefit disadvantaged smokers and our smokers in high priority groups, and they're the ones that are likely to drive down the inequalities in tobacco. We also need to acknowledge that what might work for more advantaged smokers may not work for other smokers, and people experience various types of barriers and influences on their socio-economic status and various problems. And so we need to get creative and open-minded, and we need to support perhaps high-risk research and intervention and program development. And we also need community around this and some leadership and community around this. And in the US, there is a network for tobacco disparities that's supported by the Society for Research in Nicotine and Tobacco, the SRNT. And there's no reason why we can't have an Oceania high priority groups network. And this was touched on in the pre-conference workshop on Monday, and there is already a lot of interest in joining such a network. Finish off with some Smoker wisdom quotes, no one escapes from it. You either quit it or it kills you. You know, all it does, it costs you heaps of money, makes you smell like shit, and it makes you unfit. It's so true, isn't it? And quitting smoking has made me feel happier. I mean, I've always known that you can do anything you want, but actually quitting smoking did make me feel good because that was one of the things that was holding me back. These people deserve our attention and our priority. Thank you.